Okay, we're back. And in this set of video lectures, we're going to continue talking about documentation basics, this time focusing on progress notes, authentication, signatures, templates, and other things. Okay, the progress notes we see referred to in both inpatient and outpatient records, and these are notes that basically talk about the clinical treatment the patient had during their encounter, be it a hospitalization or in the outpatient setting. We can produce this a number of different ways. The physician can speak into a device and it gets transcribed. That process is called dictation. Dictation is when the physician speaks and somebody either listens to the recording of it and types it, or they use voice-activated transcription and it Dragon Voice and some of these other programs that will interface with an electronic record. There still is some dictation, but the thing that's becoming really much more popular is the use of templates. You can see templates used in Epic, Cerner, and many other things for history and physicals, for consults, office visits, all different types of things. And we'll talk more about templates in a little bit. Electronic health records, we still do have some clinics that use paper records, but as time goes on, we are seeing fewer and fewer of them. Some things that you need to include in progress notes: date and time when it happened. Of course, with electronic health records, this is very straightforward. Everything is date and time stamped. They need to be authenticated, which in a paper world would mean a signature or a signature stamp. And basically this does, whether it's electronic or whether it is hand signed, or as the lawyers would say, a wet signature, it basically authenticates. It's showing that the provider is signing this note, right? For the most part, we don't allow initials. Of course, it really doesn't matter. With electronic health records, you key in your code and things are automatically signed and authenticated. Sometimes auditors will request signature logs, and this is basically a list of all the encounters that a provider has signed with the date and what have you. Sometimes payers will require attestation statements, right? And these can be submitted if they are missing. Electronic signatures, there's a number of different ways they can do it. Some systems will require providers to enter their provider ID number and click submit, right? And essentially it does the same function as a wet signature. This is addressed also in the Health Information Portability and Accountability Act, which we know as HIPAA, right? And there's specific guidance you can read on the CMS website in the Medicare Program Integrity Manual that talks about the kind of things that you need for electronic signatures to be valid. Templates are very, very popular now with electronic health records. At Kaiser Permanente, we had a number of templates, everything from op reports, pathology reports, radiology, even clinical trials would have these templates, right? And when auditing medical records, it's always important to find out what kind of format they're using and if they're using templates. And we'll talk about the benefits and the disadvantages of templates in just a little bit. The advantages of templates is it's much faster. I use templates sometimes on Moodle, as some of you have commented on. It gives a nice kind of uniform layout. It serves as a reminder to do certain things, ask certain pertinent questions. So like an orthopedic consult for a possible joint replacement, you can go to the clinical library, move in all the pertinent points that you have to address and discuss in the note, the patient's weight, age, so on and so forth, right? They also facilitate data collection. You can set up templates where you're collecting data into a field, say like in a neonatal intensive care unit, where you're collecting APGARs, right? So the APGAR score gets entered in by the provider in a template. And then when a programmer needs to mine that information for the state, that you can just print a report and program a report and do it. So they have a lot of benefits. They help ensure adequate documentation. Dictation and transcription can be expensive. Either you're paying somebody to type the report or you're using software that's going to be doing it automatically. Either way, there's a cost, and you can kind of minimize that by the use of templates. And again, as mentioned, templates, we can use evidence-based guidelines, or as we like to call them, clinical pathways, clinical guidelines, and kind of incorporate that into the template. And you can update these and import them. Providers at Kaiser Permanente, when I used to train people on electronic health records, used to trade templates around when something new came out all the time. But there's a downside. The downside is they're kind of time consuming, right? And if you're not updating them, they aren't always compliant. And again, it says here may need a variety of different templates. You will need a variety of different templates for different types of patient encounters. Oncologists do entirely different things than orthopedic surgeons or OBGYNs. So at one point, we had over 300 different templates just in the first year of using Epic at Kaiser, right? And again, another downside is that the practitioners don't always get trained. If you think about starting any new job and learning a new computer system, as some of you undoubtedly had to do, you have that. And then, of course, what do you have? You have to learn how to find all these templates. And again, a common way that we now document in notes, and this will make sense for some of you who have taken CPT coding and learned about evaluation and management key components, is we have the history, exam, and the medical decision-making, right? Everybody's familiar with that from E&M. If you've taken CPT coding and E&M coding, and this kind of maps into the SOAP notes. SOAP meaning subjective. In other words, the history of present illness, right? When did the pain, the signs and symptoms start? That's the history. The objective is the examination. So what does the patient present with? The patient presents with a mass, swelling, whatever it is, right? Then we get into the assessment and plan. And that's part of the medical decision-making, right? The assessment and the plan. We'll let you read the example on the SOAP notes on your own, but now I'd like to spend some time talking about operative reports, or operative records, as they're sometimes called. And you can set up templates for this as well, and they vary according to the circumstance. A cardiothoracic surgeon doing a video-assisted thoracoscopic surgery will have a different looking operation report than somebody's having bypass, right? And what the operative record is basically a narrative report of the procedure, right? It could be of a minor nature, done in a physician's office, or it could be something full on that's being done in the hospital setting. And there are two different parts to it, right? So you have the heading and all the other types of things, the more administrative things, the date of surgery, the patient ID, preoperative diagnosis, postoperative diagnosis, which may or may not be the same. What's the name of the procedure, the name of the primary surgeon, and then very important, the co-surgeons or assistant surgeons. Many cases, types of surgeries, cases as the surgeons call them, require co-surgeons or assistant surgeons. Then the body of the report gets into the narrative of the surgery, which is over on this side. And that's the position and the draping of the patient, what kind of anesthesia they got, the approach, the identification, the incision, all these other different types of things. And for those of you who are taking HIM 271, this kind of lines up with the types of things that you'll need to look at when you code hospital procedures. And again, how do you read and code operative reports? Well, basically, you have to get something to work from. Sometimes what people will do is to print them and make a ruler, use a ruler and a highlighter to scan for these things, right? If you're using a coding at a facility that uses paper records, please make a copy of it. But basically, this kind of essentially is a great way when you're new to coding these procedures to figure out exactly what happened. And again, sometimes it's helpful to have a medical dictionary. So how many of you would understand that undermining is a cut in a horizontal fashion versus taking down being taking apart, right? So this is where a medical dictionary is very, very useful. Of course, now, of course, we have all these things, YouTube, where you can actually look at what a procedure is and get a better understanding of the operative report. And again, once the CPT codes are determined, right, because of medical necessity, anything we do has to be related to a diagnosis. So that's where the ICD-10 diagnosis comes in, which we'll talk about in the next chapter. So how does this documentation affect the coding? Well, one, we need the current books. One facility I'm familiar with always was getting denials, and then come to find out they weren't using current CPT, ICD-9 at that time, and HCPCS books. So as a result, the codes were invalid when they were being submitted and they got denied, right? Other thing to do is to bear in mind that codes change every year, and during COVID, they changed sometimes several times within a year. So we want to make sure that we're up to date on the latest CPT and ICD-10 guidelines. You may want to consider, if you use a product like 3M Encoder, CPT Assistant, and Coding Clinic by AHA usually are bundled into that. And when you use an encounter, the CMS 1500, the super bill, the charge ticket, right? Use the exact CPT code and description, right? And they always want to code directly from the chart note or the operative note itself, not get into doing some of the other things. And that's all I have for you on documentation basics. Come back for the next set of lectures, which will talk about ICD-10 CM. Bye now.